Hello, I'm Mally Schansfeld, Managing Editor of Implant Practice US, a MedMark publication. Welcome to a CE webinar with Dr. Dan Holtzclaw and Dr. Justin Moody. In our webinar, we will be discussing restoration techniques for the severely atrophic maxilla. Before we get started, I'd like to invite viewers to use the question and answer box to ask any questions, and they'll be answered at the end of the session as time permits. Now I'm pleased to introduce our speakers for today. Dr. Dan Holtzclaw is a diplomate of both the American Board of Periodontology and the International Congress of Oral Implantologists. Long recognized as one of the world leaders in full-arch implantology, Dr. Holtzclaw has published over 60 articles in peer-reviewed journals, in addition to multiple textbooks. Dr. Holtzclaw has served as editor-in-chief of the Journal of Implant and Advanced Clinical Dentistry for 13 years, in addition to serving as an editorial board member and editorial reviewer for 6 additional dental journals. With over 200 main podium lectures provided at major dental conferences all over the world, Dr. Holtzclaw has been named a leader in continuing education by Dentistry Today Magazine for the past 19 consecutive years. Currently, Dr. Holtzclaw serves as Director of Fixed Arch Solutions, the Affordable Care Network of dental clinics, and Chief Clinical Officer of Advanced Dental Implant Centers. Dr. Holtzclaw is a proud 13-year veteran of the United States Navy. Also joining us today is Dr. Justin Moody. Dr. Moody graduated from the University of Oklahoma College of Dentistry in 1997. He attended the prestigious Mish International Implant Institute, where he was awarded a fellowship and mastership. He has earned fellow and diplomate status in the International Congress of Oral Implantologists, fellow and associate fellow status in the American Academy of Implant Dentistry, and he was one of the youngest diplomates in the American Board of Oral Implantology Implant Dentistry. Dr. Moody is an adjunct faculty at the University of Nebraska Medical Center, a mentor at the Coys Center in Seattle, Washington, and an honored fellow of the American Academy of Implant Dentistry. Understanding how important continuing education is to today's general dentists, Dr. Moody founded Implant Pathway in 2014. Then in 2017, he helped found the New Horizons Institute in Tempe, Arizona. This 501c3 nonprofit clinic was designed to help those who cannot afford dental implants, as well as day-to-day dentistry involved with the treatment. Today, Dr. Moody calls Scottsdale, Arizona home, where he devotes his time to Implant Pathway and New Horizons Institute and continues to see patients in his private practices. Thank you both so much for joining us. Let's dive right into this interesting topic, and I turn the webinar over to you for our presentation for today.
All right, thank you. Justin, how are you today?
I'm great. Happy to be here.
Excellent. Well, I think, happy to be with you this afternoon. And I think we have a very interesting topic with, full arch immediate load cases, commonly referred to as all on X, definitely become a mainstream treatment over the past 20 years. With more and more of these being done, we're starting to see more extreme cases and also cases that need revisions, that were done a long time ago in the past, all on X style. And I think this topic today will be very apropos to a lot of the treatment that is currently very hot topic amongst the continuing education world of dentistry. And with you being running Implant Pathways, definitely you're at the forefront of continuing education. And I think, is this a topic that you hear a lot of requests for from your students that come through Implant Pathway?
Yeah, I think about back in 2016 when we formally put Implant Pathway together, and the majority of our education was based on one single tooth implant dentistry, and there was some some talk of the all on 4 with Palomalo, and that was gaining some traction. Clear Choice and dental centers like that were starting to make some noise in that, and then you fast forward to 2023, where I would say closer to a third to maybe even half the amount of calls that the Implant Pathway fields are in doctors looking for education in full arch treatment solutions. Yeah, so that times have changed, and I think this webinar is very timely, especially some of the things that you talked about. Revision surgery doesn't necessarily mean that things went wrong. One of the things we know about in implant dentistry is if you have someone that had a full arch treatment done 20 years ago, what we know is like these treatments aren't necessarily forever. I mean, we would love to have them last forever, but they don't. And when they go south on us, what we know is biology breaks down. Bone disappears, soft tissue disappears, and the ability to anchor the next generation of prosthesis on that becomes more challenging. And the dental world has a debt of gratitude, I think, to you in your pursuit of excellence in remote Anchorage and trying to take these patients, not just for revisions, but some people have been a dentalist for forever, right? That just are out of bone. And so this is going to be a great topic.
Well, thanks. So I'll tell you what, why don't we dive into it? I'm going to go ahead and get my screen shared here and get this topic rolling. All right, you able to see that okay?
Yes, sir.
All right. So what we'll be talking about today is remote anchorage solutions, making the impossible possible. And in our clinics at Advanced Dental Implant Centers, we focus primarily on fixed arch solutions same day, and a lot of the treatment that we see are these more extreme cases, patients that are missing significant amounts of bone, like you talked about, Justin, where maybe they've been in a denture for 10, 20, 30 years, and they've been told they don't have any bone. Or we have other patients that had some dental work done, and perhaps as time has gone on, the dental work has started to break down, bones started to break down, and these patients lose bone, and there's just not quite as much there to work with. And so what we're going to show are some possibilities that patients have available to them now with some of these newer techniques that have become a bit more recognized in amongst the dental profession. And with full arch immediate loading, we've talked about, we've got 20 years of data on this. You mentioned, Dr. Palomalo earlier, his first publications came out in 2003. And with that, was showing that, this style of treatment for full arch immediate load can work. And, now as time's gone on, we have 20 years plus data on this, done by authors all over the world using all kinds of different implant systems, all kinds of restorative materials. And, the literature is very clear that the implant survival rate for this, is 98+%. Prosthetic survival rate is close to 100%. And, so if this works so well, the question that we have is, why do we need any changes? Why don't we just keep doing what we're doing? Well, you do get patients that come through the door that look like this. Patients that have just absolutely no bone. And it doesn't matter how great of a bone builder you are, what types of special techniques that you use to rebuild bone like this is going to be very challenging, if not impossible. And there are a lot of patients like this, patients that, have been in dentures for years or decades, patients that have history of trauma, patients that have history of cancer treatment. And these patients, before, many times didn't even seek any treatment because they've been told so often there's just nothing we could do for you. You're just stuck to a life of dentures, use glues, and that's all we could do for you. Well, now when we have patients like this, Brandmark who's considered the father of implant dentistry, is also, really one of the fathers of remote anchorage. Did the very first zygomatic implant back in 1987. And these were to treat patients that had, cancer, revision surgeries. And, Brandmark noted that Mother Nature has given us this area of dense bone that we can utilize to anchor implants into and give people back their teeth. Because prior to this, they were doing these big, giant bone graft surgeries, oftentimes taking hips. And the success rate, even with all this significant bone grafting, success rate for the implants was still very low, low 80 percentile range. And the patient was having to go through, secondary surgeries, heal, have, complications, pain. And so Brandmark recognized, there's other areas in the head where we can anchor into, today we call it remote anchorage. So we owe a debt of gratitude to Dr. Brandmark for not only implantology, but remote implantology. So we have a patient like this that comes in. We see there's no alveolar bone that remains. We see that alveolar ridge is gone. Sometimes we refer to this as a pancake ridge. This patient, if they're wearing a denture, is going to have to use a lot of glue. It's still not going to fit very well. But when this patient now walks through the door, and I see these huge, nice, thick zygomas. These cheekbones. This gives us that area that Brandmark was talking about, where we can anchor some implants to and really turn this patient's life around as far as their dental condition is concerned. And so that patient I was just showing you was a real patient that walked through the door. And this patient had been, was actually referred to me by an oral surgeon and was one of their family members. And he had done grafting procedures. I think he'd even done hips, sinus lifts, had placed implants, and just over time, the implants ended up failing. And there just wasn't very much bone left. And utilizing some of the remote anchorage procedures we'll talk about today, we're able to place these pterygoid implants, quad-zygomatic implants, nasopalatine implants, and give this patient back, a set of teeth to chew with, all basically in one morning without any bone grafting. And so these are the kind of cases that we'll talk about here today. So the remote anchorage market, this is all from published data. I recently published a textbook on remote anchorage procedures and did a lot of research on this, over 1,700 articles that I read through. And in published data, we see that there's 40 million edentulous patients just in the United States alone. Now we know that all of these patients will not be able to afford the type of treatment that we're talking about today. So if we even said 99% of patients could not afford this, only if 1% of patients can afford this, that's still 400,000+ patients. And then if we look at the lit, it's telling us that 16% of patients or so are what are classified as a Zaga 3 or 4, basically meaning that they're going to need quad-zygos, pterygoids, some of these, really extreme remote anchorage procedures. And multiply that data, that gives you about 66,000 potential quad-zygo patients. And with the average cost of this around the US, you're looking at close to a $2 billion market just for quad-zygos. This doesn't even include single zygos, Zaga 1, Zaga 2 patients. So, the market for this is very, very large. And this is just in the United States. The thing is that a lot of these patients had been told for so long that there was nothing that could be done for them. A lot of them just have never sought treatment. So we know that there is a very big market for this. There are a lot of patients that we can help with this. And we're going to go through some of the reasons why we'll place some of these implants and what they are and how we can help the patients. So zygomatic implants, some of the reasons for these are going to be prosthetic support in cases of severe maxillary bone loss. So these patients that, like we just showed, that have been in dentures for decades, that have no bone left, zygomatic implants can help them. They can allow us to avoid bone grafts. So we know from Brandmark's earlier studies showing that implant success rates in these very large grafted cases were relatively low. We can avoid these bone grafts. They can be utilized as a rescue implant. So some of these older all-on-X cases that maybe they've been in function for 15, 20 years, where some of the bone's starting to break down. Zygomatic implants can still resurrect and rescue these cases. pterygoid implants. So some of the reasons we would need a pterygoid implant would be for additional support, meaning we can use them for increasing composite torque value, where basically if you're adding up all the torque for inserting the implants, this gives us our CTV. And so sometimes you have patients that have soft bone, we can add some pterygoid implants to increase the composite torque value. You can maximize AP spread. So with a pterygoid implant, we'll show where they go. When they're placed essentially posterior to the sinus, you are getting the maximum AP spread that you can get. You can't get anything better than this. This is also going to allow us to eliminate cantilevers. So the literature is also very clear that most all-on X style treatments, a lot of the prosthetic problems tend to be related to cantilevers. Longer the cantilever, more problems that you have. So if we can eliminate a cantilever, that's really going to help our restoration and the lifespan of our implants. Pterygoid implants can allow us to avoid sinus lifts. Like a zygomatic implant, they can also be utilized as a rescue implant. Matter of fact, that's how I started using pterygoid implants a long time ago. And pterygoids can also be an alternative to a zygomatic implant in certain situations. So transnasal implants, these are a newer style of implant, literally not even 5 years old in the literature. And we'll cover some of these. Now, transnasal implants are a remote Anchorage style implant that can give us support to eliminate an anterior cantilever. So a lot of times we think about cantilevers and we're always thinking about the posterior, because traditionally with a regular all-on-X style treatment, you would have a posterior cantilever, where the sinus is. But with some of these extreme atrophied cases in the maxilla, sometimes you have an anterior cantilever and there's no support in the anterior. And so a transnasal implant, which will show anchors essentially up into the side of the nose, is eliminating anterior cantilevers. And they're also allowing us to preserve the option for a quad-zygo. So this implant can take the place of the anterior superior zygomatic implant in a quad and allows us to basically preserve the superior portion of the zygoma for a future implant if ever needed down the line. So transnasals are a nice new addition that have really just popped up within the last few years. They can also increase composite torque value, just like the zygomatics and the pterygoids can. Nasopalatine implants. Nasopalatine implants been around for a while, but many times are overlooked. These can also help to provide anterior support, like the transnasals, eliminate cantilevers. They can't be used in all cases. It depends on how much bone is available, but it's something that's often overlooked. And again, they can increase the composite torque value just like all the other remote anchorages can. So we talked about cantilever a lot. Why do we want to eliminate the cantilever? Well, literature is very clear on this. Cantilevers increase stress on the terminal peri-implant bone. So in a typical all-on-4, all-on-X style situation where you have an angled implant right in front of the sinus, you are getting a lot of stress on the bone when there has been a cantilever. So if we look at some of the publications in the lit here, we can see that when we have a cantilever, we're starting to get a lot of stress concentration at the distal portion of the angulated implant. This can cause screw loosening, prosthetic screw loosening. It can cause abutment screw loosening, which can lead to screw fracture, which can lead to prosthetic problems. And LIT's very, very clear on this. There's tons of studies that show just through normal functioning and use of these restorations, you will get screw loosening as time goes on. And that's where maintenance becomes very important on these procedures, where we have to replace the screws, retighten the screws, make sure they have the proper torque value. Some other reasons on eliminating the cantilever, there was a great study that came out in 2001 by Wilkerson. And they basically looked at some all-on-4 style setups and compared them to some setups where pterygoid implants were added to eliminate the cantilever. And this was looking at finite element analysis, where they evaluated the von Mises stresses around the bone. Basically, the key finding from this study was that if you add a pterygoid implant to an all-on-4 style treatment, you reduce the stress in the crustal bone of the terminal angulated implant by nearly 382%. So if we see a case like this, where we have regular all-on-4 style treatment that's going to have a cantilever, we can see all the stress in this peri-implant bone on the terminal implant. When we add a pterygoid implant here, we're eliminating the cantilever. And because we eliminate the cantilever, we are reducing the stress on this implant by 382%. So significant amount of help for the bone in that area, which is going to extend the lifespan of the implants, which is also going to extend the lifespan of the restorations. And so really nothing but benefits that we can have by adding a pterygoid implant. So essentially the lit shows us that by adding this to an all-on-4 style treatment, we are reducing the peri-implant bone stress on this implant by 382%. So that's quite significant. So I was recently in Italy giving a lecture, and I was asked to talk about future trends in implantology. And, from that lecture, we were talking about where do we go from here? Well, if we look at contemporary and future surgical trends in full arch treatment, we're getting a lot more utilization of alternative remote sites such as transnasals, transsinus, which will cross through the sinus and anchor into the lateral nasal wall, essentially, nasopalatines, zygomatics, pterygoids. We have a lot of guided protocols coming out, robot guidance, haptic guides, stackable guides. We're also starting to see a resurgence of the old periosteals, but the old periosteals now have been updated because we have computer technology. And so now we can use our CAT scans, we can use our 3D scanning, and we can use CAD/CAM design to design a new style of subperiosteals. So we're starting to see a little bit of that come about now. We have new protocols that we're developing, and we'll talk about this particular protocol called the Patsy protocol, which we're using for severe atrophied maxilla. We're going to start seeing a lot more complications on these full arch cases because, one, there's a lot more doctors doing them now of much more varied skill sets. And if you think about all of the older All-on-X publications, these publications were typically done by very, very experienced clinicians. And oftentimes now we'll have doctors who maybe one day out of dental school who are attempting these procedures. And because we're going to start seeing more complications, so we're going to have to deal with those. And then, as you mentioned, we started this webinar, revision cases. And as more and more of these cases are being done, and as time goes on, LIT's pretty clear in showing us that the longer they're in function, the more implant failures we'll have over time, even if everything is done perfectly, because we're dealing with the body. And really, there's nothing that we purchase that we expect to last forever. I mean, you buy a car, you're not expecting it to last forever. Most people tend to end up getting a new car every 5 years or sooner. You buy a refrigerator, you don't expect it to last forever. I mean, really nothing you buy, you expect to last forever. And for some reason in dentistry, sometimes we expect things to last forever, even though we are involving this with a biologic system. And the mouth's a very dirty place naturally. We have billions of bacteria there, yet for some reason, we sometimes expect these cases to last forever. And that's just not reality. And, our colleagues on the medical side, they do a knee replacement surgery. They're not expecting it to last forever. There's knee revision surgeries done all the time. And dentistry is no different. And as we have more of these cases done, and a lot of them are getting longer out in their lifespan, we're going to see more revision cases. And when they need revision, they're going to have less bone. And so we're going to need these remote anchorage style treatments for these cases. So I'm going to show you some sample cases here, some revision cases, and just some of these cases that we talked about before where these patients, weren't coming for treatment before. But now that we have the internet, we're showing some of these types of treatments that are available. We have some of these patients that are now starting to come out of the shadows that are seeking treatment, seeking a normal life as far as their dental condition, oral health is concerned. So this particular patient presented to our office, a patient that has Goldenhar syndrome, and that's hemifacial microsomia. So we see this patient has very, very small zygomas. And, typical zygoma will be up to 20 millimeters tall. And, this patient's zygoma is about 6 millimeters tall. So we can see very, very short. This is why the patient has hemifacial microsomia and very thin. And this patient was in her 60s and had been told, there's really no treatment that we can do for you. And that's why she'd been in a denture her whole life and, had never had implants and had been with, unable to just enjoy some of the normal things that many people take for granted, such as being able to eat whatever food she wants to eat. And so with this treatment, we go ahead and reflect a flap, and we can see the bone's relatively thin. And we start this off with some remote anchorage. So we're placing a pterygoid implant first. And there's many ways to do a pterygoid implant. This is a technique that we teach in the textbooks utilizing drills and osteotomes. We then move anteriorly. When we move anteriorly, we are cleaning out the nasopalatine canal, place an implant, and you can see we get very high torque here in the nasopalatine. Now we move to the middle. And we move to the middle, we are placing a zygomatic implant. So we're accessing the zygoma, so dissecting up to the zygomatic notch, access the sinus, lithoschneiderian membrane. Now we are utilizing an extra sinus protocol and using our longer drills here to engage the zygoma. And we see this case, we have pterygoid implants, zygomatic implants, nasopalatine implants. We're able to close everything up and restore the patient immediately on the same day. So where this patient had, lived her entire adult life with no teeth, been, wearing a denture this whole time and was told there was no options for you, we're able to literally in one day give her back teeth, utilizing some of these remote anchorage procedures. So in that implant sequence, as trying to subtly point out, we started in the posterior, then we moved to the anterior, and then we basically moved back to the middle. And this is a protocol that we had developed in our office in Texas. Me and my colleague, world maxillofacial surgeon, Dr. Juan Gonzalez, that we call the Patsy protocol. And this is what we use for treatment planning and directing all of our fixed arch treatments for severe atrophy. And what Patsy stands for is pterygoid, anterior, then tilted implants, which could be just standard tilted implants or transnasal or transsinus implants, and then zygoma. So we follow this Patsy protocol for all of our severe atrophy cases. And we'll show how that works. And when we do this, we may have a regular all-on-X style case like this. We may have an all-on-X style case with pterygoids, which we call a fast case or a P-fast. We may have pterygoids, zygomatics, and anterior implants. We may have a quad-zygo with pterygoids. And we may have a little bit of all of the above. And by following this protocol, it basically guides us and dictates us as to how we're going to utilize this remote anchorage to achieve our end goal of getting the patient back teeth on the same day. So when we're doing this, we are always placing a pterygoid implant first. We're attempting to place a pterygoid implant first. And once we have a pterygoid, we want this because we're eliminating posterior cantilever, we're maximizing AP spread. So really no downside to placing a pterygoid implant. Next, we're going to move to the anterior. So when we go to the anterior, we can place a standard implant just in alveolar bone. If we can't get that, maybe the patient has too much bone loss or the bone's too soft, we could maybe place a nasopalatine implant. Nasopalatine, unsung hero in many cases, often overlooked, but it's a nice place to get some good torque. Maybe we can't get that. Maybe there's just not enough bone up there. Well, this patient maybe is a little bit more resorbed. We're going to try a pterygoid first. Now we're going to go to the anterior. So now we might be able to do one of the newer style implants, like a transnasal, and we'll go into what that is. And if we can get a transnasal implant, great. Now we have anterior support. And with this style of implant, for those who haven't seen it before, it basically is going up through the nasal cavity. We're dissecting the nasal tissue away. It's anchoring up into the bone at the confluence of the inferior concha, the lateral nasal wall, and the frontal process of the maxilla. So we're getting the bulk of our support, insertion, torque, and stability all from up here at this bone, way up in the side of the nose. And so this is for more extreme atrophy cases. And when we have posterior support, anterior support, now we look for mid support. And we could try that with a standard tilted implant. Maybe we can't get a tilted implant because the bone's too soft or the sinus is too pneumatized. But if we can, we have a case like this where it's just a standard all on X with 2 pterygoids. If we can't get that, so say we have no torque for that implant, now we can maybe do a transsinus implant. So the transsinus implant's going to extend through the sinus into the lateral nasal wall, like we see here. And so now we have our posterior support, anterior support, mid support with our transsinus implant. Now, what if we can't get any mid support? Well, if we can't get any mid support, now we go look to the zygoma. So the zygoma is really nice, dense bone up in the cheekbone where we can get mid support. And so if we can't get any mid support, say with a tilted implant, now we can move to a zygoma. So in this case, we have pterygoids for posterior support, anterior support with standard implants, and then zygomatics that are anchoring for mid support. So if we have a pterygoid implant and say we can't get any anterior support, so no nasopalatine, no regular anterior implant, no transnasal. Well, now we have to do basically a quad-zygo because we need a zygomatic implant to give us some anterior support. And then we're going to need a zygomatic implant for mid support. And so some of these patients, we're going to have to place 2 zygos. And so we see this case here, pterygoid implants for posterior support, quad zygos for anterior mid support. Now, if we have a pterygoid implant, it can change the position of where we're placing our zygos. So this is a parallel setup. So what we want to avoid is something called crossing swords. So if we have 2 zygomatic implants and they're bumping into one another, we really don't want this because one, we're not getting quite as much stability for these implants because we don't have as much bone to implant contact. So we want to ideally spread the implants, as far as possible in the zygoma, just like we would for standard implantology. Ideally have a couple millimeters, 2 to 3 between the apices of these implants. So we really don't want the apices of these zygomatic implants touching one another like we see in this zygomatic cross section here. Ideally, we'd like to have something like this. So in this zygoma, we can see there's 2 implants. We have space between them. We have more bone to implant contact, going to have more stability, and likely less future problems with them. So this is where a pterygoid can kind of set the tone for the entire procedure. Now, in all the other cases I've shown so far, we're able to get a pterygoid implant for posterior support. So what happens if we can't anchor into the pterygoid? And pterygoid can be a very finicky area of bone to engage. And it's not always possible to get a pterygoid implant. So if we're not able to get a pterygoid implant, and we're not able to get an anterior implant, and we're not able to get a tilted implant, basically that just leaves us with zygoma. And if we're only left with zygomatics, we're having to do a quad. Now, before I showed you a parallel setup. Now, the issue that we run into if we don't have a pterygoid is with a parallel setup, we're not getting very good AP spread on our implants. It's going to give us a little bit shorter restoration. So we see on the screen here, we've got 2 parallel implants, but our restoration is going to be a little bit shortened. If we move the implant, so you can see if we move this posterior implant a little bit more to the distal with the platform, that allows us to widen the AP spread and can give us a longer restoration with a little bit of cantilever to give the patient more teeth to chew with. So if we can't get a pterygoid, we can change the position of the implants from a parallel setup to more what I call an A-frame setup to give us a wider AP spread. So if we look here, we can see a parallel setup. We're able to get a pterygoid implant for posterior support, remote anchorage. Now that allows us to place 2 zygomatics. And because we're not really having to worry about the AP spread, we can parallel these. And when we parallel these, this makes it a little bit safer for less experienced surgeons that are doing this because it keeps the apex of this implant a little bit further away from the eye. As opposed to this case on the right, which we call an A-frame setup. So here you notice we pretended that we weren't able to get a pterygoid implant. Since we weren't able to get a pterygoid implant, we moved the platform of this zygomatic implant as far posterior as possible. But as we move it more posterior, it brings this apex more anterior. And that increases the chances of your apices bumping into one another. So this technique can be a little bit more challenging compared to, say, the parallel setup. And in order to do a parallel setup, you ideally need a pterygoid implant so you can maximize your AP spread. So we can see the A-frame setup going to give us a lot more AP spread compared to what we'd see between two zygomatics in a parallel setup. So the pterygoid implant, that's one of the reasons we place them first, is it sets the tone for the rest of the case. So if we look here, we can see on this model, we placed the pterygoid implant to show posterior support with a parallel setup on this side. So we're able to bring this a little bit more further forward and parallel these where they have less chance bumping into one another and easier to stay away from the orbit. On this side, we pretended we weren't able to get a pterygoid implant and did this side more an A-frame setup to widen the AP spread. So if we look on this side with the parallel setup, we have our pterygoid implant. We have these implants parallel to one another. Again, keeps us a little bit further away from the orbit, but it minimizes our AP spread. So we can see here a little bit less AP spread, but it doesn't matter because we have a pterygoid. If we go to this other side of the model, we've now pretended that we weren't able to get a pterygoid implant. So to maximize AP spread, we've had to put the platform of the zygo a little bit more to the distal, which allows us to widen the AP spread, have less cantilever, because we don't have this pterygoid implant in the back for support. So if we look at this restoration, we can see we were able to get a pterygoid over here. And with a parallel setup, we move these more anteriorly, less chance of the implants bumping into one another, but our AP spread is less. But the pterygoid implant really negates that. On this side, the pterygoid implant was not able to be engaged. And so an A-frame setup is done over here. So we can see the two zygomatic implants here have a much wider AP spread, still have a little bit of cantilever, but fairly minimal. But you can see how much further this axis has been distalized by doing an A-frame on the zygomatic implant compared to the pterygoid. So the pterygoid implant kind of sets the tone for the whole rest of the arch with a Patsy protocol. So we'll show a sample case of how this is used. So we see a patient like this, and this patient has severe amount of atrophy, a lot of bone missing, and this patient would be very difficult to treat with standard treatment. And so we go ahead and do our fleck reflection, and you can see this ridge is really, really thin. I like to call these potato chip ridges sometimes in the office because they're literally as thin as a chip. So we go ahead and place a pterygoid implant first. And you can see just how thin some of this bone was. I mean, there's virtually nothing there for us to work with, less than a millimeter. I mean, you're talking fingernail thickness here. We do have a little bit of zygoma bone here. So let's start in the back first. Posterior pterygoid implant. Okay, we get really nice torque here. So a good 45 plus Newton centimeters of torque. Now we're going to the anterior. Well, we see from the CAT scan, there's just no bone here to work with. So there's no nasal, there's no nasopalatine, there's not going to be any transnasal here. So that tells us we're going to do a quad-zygo. So here we go ahead and place two zygomatics in a parallel setup. And we're going to now do that on the other side. Now on this patient, because we were able to get a pterygoid implant on this side, we did a parallel setup with these zygos. On this side, was not able to get a pterygoid implant. Sometimes they're just hard to engage. And this, we do more of an A-frame setup. And so with the A-frame setup, you can see it brings the apices closer together, but it is allowing us to have a wider AP spread. So on this side with the parallel setup, we can see a bit more space between our zygomatic implants and this cross-section of the zygoma. On the other side, where we have the A-frame setup, a little bit less space between the implants, but we're still not touching one another. If we look at this setup, again, we can see more AP spread with the A-frame. A narrow AP spread here, but the pterygoid implant negates that because we eliminate the cantilever and we maximize the AP spread. So just the way that Patsy protocol dictates how we're going to use remote anchorage implants throughout our case. Right, and this patient's immediately restored. So even though she had that very thin potato chip ridge, where in the past she might have to undergo a year plus of bone grafting treatment, sinus lifts, we're able to get her all restored in literally one morning. So we look at another case. This is another typical patient that will come through our doors in the clinics, been in a denture for a long time, severe atrophy, similar situation to the last patient, just not very much bone to work with. So we look at the zygos, we can see that one side's a bit thicker than the other, but they both look really nice and dense. And you look down at the ridge here, you can see it's pretty thin, not a whole lot to work with here, but doesn't really matter because we have all this dense bone up here that we can utilize for remote anchorage. So we go ahead and reflect the flap. We place a pterygoid implant first. Now we move to the anterior. We move to the anterior. We are now doing a piriform rim implant. So we now have anterior support. Okay, now we go to the middle. The middle, we are engaging the zygoma. And we go ahead and place our zygomatic. So you can see posterior support with the pterygoids, anterior support that's engaging up the piriform rim, and mid support with the zygomatic implants. And we go ahead and suture that up. We can see no cantilevers. We have nice platform positionings. We have good adequate support everywhere. So I would anticipate this restoration hopefully will last the patient the rest of their life. See our 3D CAT scan rendering, nice anchorage, all remote, pterygoids, zygomatics, piriform rim. All right. Another case, we have a quad-zygomatic implant, pterygoids. And this patient, you may look at it and say, well, that patient doesn't really look like they need this type of remote anchorage treatment. But we analyze this a bit further. We take a look at where the nasal cavity is, where the sinuses have pneumatized, and where our anticipated level of bone reduction is. So with our bone reduction, we look like we're probably going to get into the sinus, which doesn't leave us a whole lot of anterior bone to work with. And if we look at the bone where this bridge was, where the pontics were, so we focus in on this bone right here, we can see that there's just not a lot to work with. I mean, less than a millimeter of bone here, just slightly more than a millimeter of bone here. Even with the best bone grafting procedures, it's going to be very challenging to rebuild enough bone to work with here. So if we're planning out this case, following the Patsy protocol, we do pterygoid implants first, some zygomatics for mid support. And then because we look like we have enough anterior bone, we may be able to place what we call a vomer style implant. These implants aren't really engaging the vomer bone. That's just how Jensen referred to it in his paper that talked about vomers style implants. And so following Patsy protocol, go to posterior first. And as we anticipated, we do the bone reduction. We get into the sinus. So we lift the schneiderian membrane. We place the pterygoid implant directly through the sinus into the pyramidal process, and we get posterior support. So nice torque in the posterior. Now we move to the anterior. So we move to the anterior, we're trying to essentially engage what's called the V point. Some people, layman term called the vomer. It's really engaging kind of into the bone of the nasal spine. And even though it was able to get torque here, it wasn't quite as high as I wanted. And so in this case, I abandoned the vomer style implants and did 2 zygomatics. So since we weren't able to get anterior support, according to Patsy protocol, we now go to the middle and we utilize zygomatics. And because we're able to get pterygoid implants, can do a little bit more of a parallel setup. So we got remote anchorage here. We have remote anchorage here. You can see that we have plenty of space between the implants. Go ahead and close this up and immediately restore the patient. And so we can see no cantilever, maximum AP spread, and our parallel setup. And this is what the post-op radiograph looks like. 3D rendering, again, showing anchorage remotely into the zygomatics and pterygoid implants engaging pyramidal process and pterygoid pillar. So now we start to move on to a revision case. And that was something that we talked about earlier in the webinar, is that some of these cases, as time goes on, will have implants fail. Some of these cases, as time goes on, will just simply have complications or problems. And so in this particular case, this patient was referred over and regular all-on-X style treatment was performed in the maxilla. And unfortunately, some failures occurred. And when the failures occurred, it created some massive amounts of bone loss. And so we can see in this left maxilla, back where the sinus is, that there's really no floor of the sinus left. We can see a lot of thickening in the Schneiderian membrane. And on the right side, we also have a few areas where there's holes in the floor of the sinus. There were some oral enteral fistulas. You could see thickening of the Schneiderian membrane. All of these implants in the front had failed. There's basically one left remaining. And so this patient would be very difficult to treat without remote anchorage. A sinus lift here is going to be virtually impossible because there's no bone on the floor of the sinus here. The Schneiderian membrane is already dramatically thickened. And on this side, we still have holes in the floor of the sinus. So just reconstructing the posterior maxilla is going to be next to impossible for this patient without having some major reconstructive surgery done. That's going to possibly involve hips, other areas of the body. And then this bone here, because of these previously failed implants, there's just not a whole lot to work with there either. So very challenging case if we were not able to use remote anchorage procedures here. So take a look at this and some other views on our CAT scan. We can see that in this coronal view, normally there is bone all here and there's nothing there. So again, sinus lifts can be virtually impossible here. We could see, again, no wall of the sinus here, a giant defect here, no wall of the sinus here. The sinuses are, very thickened Schneiderian membranes. And so for this patient, I had them go see ENT to have a FEST procedure ahead of time. And now following Patsy protocol, start in the posterior again. So P for Patsy, standing for pterygoid. So we start back there first. And because this patient had no bone on the floor of the sinus here, kept this flat, very minimal, to avoid disrupting any of this tissue and risk opening a hole again into the sinus. And even though there's very minimal bone back here, able to utilize the drills and the osteotome to engage the pyramidal process of the palatine bone, the pterygoid pillar, and get some dense anchorage with a pterygoid style implant. Now we move to the anterior. So when we move to the anterior, again, because this bone is very thin and we had multiple failures here before, we know this wasn't a really ideal spot to attempt anchorage again. And so utilizing a remote anchorage protocol, we went through the nasal cavity. So I lifted the nasal mucosa and dissect all the way up to the inferior concha. So this inferior concha is this little bitty bone here that juts out of the lateral nasal wall. And when it's covered with this tissue, it's referred to as the inferior meatus, but right now this is just the inferior concha, the bone. And now where this bone meets up with the lateral nasal wall and the frontal process of the maxilla, it's giving us this nice dense island of bone to engage. And so this implant is traversing the nasal cavity and the apex is engaging this dense type 1 bone. And this is where we're getting the bulk of the anchorage for this particular implant. And the very first time I was testing out transnasal style implants in the cadaver lab, I wanted to really see how much torque I could get remotely with this little bit of bone here. And so I took a 4.2 millimeter implant, and down here at the crest, I drilled a 5 millimeter osteotomy. So I know that there was no bone engagement with the implant down at the crest. And if I was going to get any stability, it was going to come from up here. And I was able to still get 50, 60 plus Newton centimeters of insertion torque. And I know that it all came from up here because I purposely drilled the hole on that cadaver wide enough to where none of this implant was going to engage the bone here. And so we know that this bone, in the right circumstances, is a dense bone that we can engage remotely to give us anterior support. And that's what we did in this particular case. And you can see a little close up, the implant crossing through the nasal cavity, engaging that bone at the confluence of the inferior concha lateral nasal wall and the frontal process of the maxilla. And now we go to mid support. And so for mid support for this patient, went with a zygomatic implant. And so with this, I am reflecting the tissue, doing quite a bit of dissection all the way up to the zygomatic notch, and then doing an extra sinus protocol, basically creating a small slot that is going to slightly go through the sinus and allow our implant to anchor into this dense bone of the maxilla or the zygomatic bone remotely. So we go ahead and close, and we always want to get primary closure on these cases. It's typically easy to do because one, if the patient's having teeth removed, there's going to be excess tissue. And even if the patient is edentulous, we're able to do often periosteal releasing incisions and ensure that we have primary closure. And so if you look at this 3D rendering of our patient afterwards, we can see again posterior support with our pterygoid implants. We can see mid support with our zygomatic implants, and we can see anterior support with our transnasal implants. So again, following Patsy protocol, all using remote anchorage procedures. We're getting very high insertion torque values, maximizing the AP spread, eliminating cantilevers, and immediate restoration of this patient. So this patient had been going through a year plus of treatment prior to this with multiple failed implants, was not able to have any immediately loaded restoration due to some of the bone failure, was wearing a denture. And again, all in one morning, we're able to eliminate that utilizing these remote anchorage procedures. And I want to share this case. This was the most recent case that I did. And in these webinars, I always like to try to throw in the last case that I did, just to show that, these cases are not something that you'll come by once in a blue moon, that it's something that there's a lot of patients that need this. And we talked about the need for revision as more of these all-on-X style cases are being done with different levels of skill providers and just time, that we're going to see a lot more cases that are going to need some revision, some help. And this patient was that exact situation. This patient had been treated and had multiple rounds of implants placed in the maxilla. And unfortunately, the 2 rounds of implants ended up failing. And fortunately, the mandibular implants were able to integrate, but unfortunately, the maxillary implants, even with multiple attempts, were not able to integrate. And where we see more problems with all-on-X cases tend to be in the maxilla, and LIT shows that we do have a little bit higher failure rate for all-on-X style implants in the maxilla. And the reason for that is just the bone quality up here. So we know that literature shows us that bone quality of the mandible is much denser. We have type 1, type 2 bone down here. Consistency of this bone tends to typically be almost like a 2x4, where the bone in the maxilla we know is more of a type 3, type 4 quality bone. So very, very soft, more of the consistency of, say, a styrofoam, almost like a floral styrofoam. And many times the bone in the posterior maxilla can sometimes be like warm butter. You can oftentimes push your drill through it without even turning it on because that bone is so soft. I mean, I've even seen bone in many occasions where it's almost liquid. Once you get through the outer cortical shell, and your assistant can literally use the suction and suction the bone. So that was really the problem with this particular case, was this bone in the maxilla was just very, very soft. Patient, you can also see, has some very pneumatized sinuses, and these sinuses, are almost coming up to the lateral nasal wall. And to make matters just a little bit more challenging, this patient has some impacted teeth. And so if you imagine when we take these impacted teeth out, there typically might be some bone here, but because there were teeth there, there's just gonna be a big hole there. So we're not gonna have any bone to work with. And so in this particular case, go ahead and we're gonna follow the Patsy protocol again. So for these severe atrophy cases, we are always trying to follow the same protocol. So starting in the posterior, we attempt a pterygoid implant. And so we are utilizing a combination of drills and osteotomes to engage the pyramidal process of the palatine bone, the pterygoid pillar. And typically, if you look at this osteotome, you can see these marks here. The typical pterygoid length implant in my hands is about 18 millimeters. And the literature for pterygoid implants is very clear, showing us that the longer the implant is, the better bone engagement that you get, up to a point. So some of the older pterygoid implant studies, we're utilizing implants that were sometimes as short as 10 millimeters. And what we're analyzing those studies is that these shorter implants are really just engaging the bone of the tuberosity. They're not really engaging the denser type 1 bone of the pyramidal process. So normally pterygoid implants are going to be 16, 18. So these longer style implants, I can tell if it starts working or not. These longer style implants in the pterygoid typically, again, are going to be 16 to 20, but they can go up to 25 to ensure that they're engaging the denser bone of the, that we need for remote anchorage. So now, because we have posterior support, we're now moving to anterior support. And so in this case, again, I was able to utilize a transnasal implant. So again, going through the nose, engaging the dense bone at the confluence of the inferior concha, lateral nasal wall, and frontal process of maxilla. And so we're anchoring remotely, getting the bulk of our torque all up here. And now we go for mid support in the zygo. So mid support, we are utilizing our zygomatic implant with a slot technique, engaging this dense bone all up here in the zygoma. And we take a look at our post-op CAT scan. We can see remote anchorage giving us posterior support with our pterygoid implants, anterior support with our transnasal implant, and mid support with our zygomatic implant. And so we add up the composite torque value here, and it was, through the roof. Composite torque value in Jensen's 2015 study, what he recommends for ideal success in all-on-X style case is a combined 120 Newton centimeters of torque. And utilizing this remote anchorage with this denser bone, this particular case probably had, over 500 Newton centimeters of composite torque value. So we look at this 3D rendering. Again, we can see our zygomatic implant remotely engaging the zygoma, nice and low. And when we're placing zygomatic implants, we want to try to go as low in the zygoma as possible because it's preserving all of the superior bone for a second zygomatic implant if we ever need it. So this anterior implant engaging the dense bone transnasally, this is now preserving all of this bone in the zygoma here superiorly in case we ever need it for the future. So if this implant ever fails, we now have the option of getting remote anchorage here. And so that's one of the reasons we want to go low in the zygoma as opposed to trying to go right in the middle of the zygoma. And now our pterygoid implant, if you can see over here, this is, you can see maximizing our AP spread. It is eliminating cantilever, so no cantilever anymore with pterygoids. If you notice these, they almost parallel one another. And even though we're doing this with a freehand technique, because we're basically following the anatomy that the body gives us, these are almost parallel to one another. And so with this particular patient, even though he had failed implants in the alveolus on multiple different attempts, by utilizing remote anchorage, anchoring into the pterygoid region, anchoring into the zygoma, and anchoring into the transnasal, we are able to give him back an immediately loaded prosthesis, get rid of his denture, and do all of this without any need for bone grafting, without any need for sinus lift. So saves him a lot of time, saves him secondary surgeries, and essentially rescues this case that was having a lot of problems. So looking at all these cases, we can see that there are a lot of potential applications for remote anchorage procedures that we can utilize zygomatic implants, pterygoid implants, piriform rim and nasal rim implants, nasopalates, and transnasal implants. We can also utilize what we call Patsy protocol. And with this, we are placing pterygoid implants, anterior implants, tilted implants, and then zygomatic implants. And depending on if we get one or the other is going to determine where the next series of implants go in treatment of the edentulous maxilla. And that concludes our seminar here. A lot of this information is in the textbook that I had recently published, Remote Anchorage Solutions for Severe Maxillary Atrophy. Would also like to mention that just at Implant Pathway, that's I know that you're having courses that are teaching this style of treatment that I'll be lucky enough to help with, at Pathway, so we can, really spread this style of treatment to different doctors so we can help more patients. And if anyone has questions, we'll have a question and answer session at the end of this webinar, but you can also email me at danholtzclaw@affordablecare.com. And would also like to mention that, if you're interested in this style of treatment, or if you do this style of treatment, you can contact us. We do a lot of this work in our Advanced Dental Implant Center network of clinics. And if you're interested in joining our clinics, either as a doctor or if you have an office and you're interested in coming with us, we can give you information on that as well. And with that, that concludes the seminar.
Thank you so much.
We're able to have a little bit of discussion now and also open the floor up for any questions that we may have. So Justin, what did you think about any of that stuff that we just covered? Any things that immediately come to mind with the, the number of doctors that come through your training center at Implant Pathway, or just things that you see just throughout your career?
Yeah, so many things. First off, very well put together. There's, and if you haven't had the opportunity to pick up Dan's book, you should, if you're at all interested in these procedures, regardless of whether you want to do them or if you have patients that are, we all know all practices have patients that are in this, this spiral of no bone and, the opportunity to not have any treatment. So, throughout my career prior to these remote anchorage procedures, the only the only solution we had in the maxilla was to sinus augment, do a sinus augmentation. And that was fine for the sinus augmentation is fine for patients that have some bone anterior to the sinuses, because you need to cut down that cantilever. A lot of the things that you said about the posterior cantilever also are true for anterior cantilevers when you're only trying to put implants in the posterior into grafted bone. And by the way, that grafted bone is going to be soft for hell. It could be soft for years. Like you stuff 20 millimeters of particulate graft in the sinus, and by the time it is of substantial quality to hang something on, like, the people aren't going to wait that long. And then they're long implants. I've long been a fan of the incisal canal implant. I find that to have great cortical bone around there, but you don't always have the bone, especially in those knife edge ridges that you are going. We know at the clinic that we see a tremendous amount of patients with pancreas that you're just not going to bode well for sinus augmentations. I also think that again, going back to the revision surgery, it's not about revising. Yes, sometimes we revise cases that have failed implants, but a lot of times we're revising long-term fixed cases that throughout time just lend us to the next step. And I think it's important to have all these tools in your toolbox, because if you have adequate bone, to not have to go to the remote anchorage, that obviously that's first line. But if the patient is young, 30s, 40s, which we're seeing today, even and I guess my question for you, Dan, is like, doing those younger cases, do you are you if they have or even marginal bone for conventional implants without remote anchorage, do you try that first to get them down the road farther, or are you confident enough in the remote anchorage, just go straight to it even on a younger person?
Well, when we're doing these cases, we basically utilize Patsy for everything. And so even if we're doing a regular all-on-X style case, we'll still place a pterygoid first because of all the benefits that we talked about, eliminating cantilever, we get increased composite torque value. So there's really no downside to placing a pterygoid implant once you know how to safely place it. Then we'll go to the front, and if they have enough bone, we'll place a standard, regular axial implant in the alveolar ridge. And if they have enough bone in the middle, we'll do just a standard angled implant. And so we really use that protocol to guide us on all of our implant placements. Now, when you talk about age, for some of these procedures, that does come up. So for example, do you place a zygomatic implant in someone that's, in their 30s, that's still considered, young? And I would say it's very situation specific. So for example, I've done, quad-zygos on a patient in their 30s, but that patient, was in a car accident at age 18 and was in a denture by age 19. So, by age 39, she'd been in a denture for 20 years. For the average patient, they might never be in a denture for 20 years because, with the age that they are, they might be in a denture for 10 years and then they pass away. So this person, even though she was 39, her situation, she just had no bone. But one unfortunate thing that we do see is with, a lot of the courses now that are teaching this, unfortunately, they're just teaching, here's how you do this. Sometimes they're not really teaching, here's why you do this, or here's, the really proper indications for this. And, that's also something on the doctor to, take into account. They're a doctor and need to really decide when's the appropriate time to use this and when's not the appropriate time to use this. And unfortunately, a lot of times, sometimes you see doctors diagnosing, what would be the best case to post on Instagram, versus what's actually best for the patient. And these, when Brandemark first came up with them, they were really reserved for patients that had history of cancer revision surgeries, severe trauma. Then we've been able to expand it to patients that have minimal amounts of bone. But then there are cases where sometimes the patient just has very, very soft bone, and that used to be one of the worst days in the clinic. I call it butter bone. When a patient just had butter bone and there was just nowhere to get torque with, these styles of implants can help. And on some cases, you might have a spot where you just need one zygomatic implant because the bone was so soft there, you couldn't get any anchorage. And what we also know that, as you do these cases longer and longer, cases where you tend to have low insertion torque, we have really soft bone, those are the areas that you tend to have more problems with as time goes on, because that bone just starts to break down over time, like you said.
Yeah, there's
before we get on,
oh.
I just wanted to invite viewers to use the question and answer feature in the control panel on your screen to ask any questions that you have. We do have questions coming in, so Dr. Moody, if you would like me to ask the audience questions, I can do that.
I think that the other thing with remote anchorage is that I think you started the webinar on is the need for posterior support to cut down the cantilever. And I don't remember the exact number, but it was 300 and some times, stronger when you put those pterygoids in there. Like that was, that should be eye-opening for many, because one of the problems with a traditional all-on, we'll call it 4. We're not like, that's what many people understand, but which is, 2 in the front and then 2 in the back angle to increase AP spread to avoid, the sinus. But in reality, like, where do you see like those the turn of that head, being, what, at the second bicuspid, maybe, and certainly not, the first molar. So those cases are bound for cantilevers, and then take a look at the patient with, large thick masseters and, all the things that you're looking at, and you're like, man, like getting back there to the pterygoid and having that anchorage. I know for a fact, had I had that in my arsenal 10 years ago when I was, doing these, that I know that I would have those that failed. I know I'd have less of those, reducing that cantilever. I just look back at my own career and I just like, that it wasn't. And it's funny too, because, having done this for, I guess I'm going to date myself, 27 years, things have gone in and out of fad, right? Like there was one, we talked about Terry's, maybe even 20 years ago, but then I think the technology of the implant itself has gotten so much better, and there was no place to learn that skill, unless you wanted to, go to Puerto Rico and watch Hill Tatum or somebody, like Cowboy Up. And, today, with people like yourself, the ability to train someone to do this reliably and predictably, to add into their practice is of, the utmost importance.
I do have some questions from the audience that I need to get in before we have to close for today.
For sure.
Okay, great. But once again, I invite viewers to use the question and answer feature in the control panel on your screen to ask any questions that you have. The question: can remote anchorage implants be used for snap-on dentures?
So, really in the literature, the remote anchorage, one of the reasons they have such high success is because they have something called cross-arch stability. And really, to gain cross-arch stability, you need something rigidly fixated. So for these types of cases, they're not commonly used for snap-on style treatment. And in the little bit of lit that has looked at snap-on style treatment with remote anchorage procedures, they definitely show higher failure rates. And these patients, are really kind of down to their last resort. There's not a lot of treatment left beyond this. And so we want to make sure that when we're employing these remote anchorage procedures, that we're doing everything possible to make sure that it's going to last. And remote anchorage just with snap-ons is not something that's really supported by any published literature.
Okay, another question. Which implants do you think are harder to do, zygomatic or pterygoid?
So zygomatic implants are always the one I think that creates the most fear with people because they're so big. They can be up to 60 millimeters long, where the standard implant people place, longest one they might place might be 13 to 15 millimeters. So you're talking, an implant that could be, 4 times longer than the longest implant, the typical implantologist is used to placing. So in addition to having these really, really long implants, you're also up near the eye. And so the eye, is something that's very scary to a lot of providers because we're used to working, in the mouth. And now we're getting, further outside of the mouth. So these, really long implants. And the longer the implant is, if you make 1 degree of change because it's so long, it's now creating a much larger degree of change, at the apex. But other than the orbit, there's really not a whole lot of anatomy to be concerned with a pterygoid or a zygomatic implant. So the zygomatic implant's actually a bit easier to place than a pterygoid implant. Pterygoid implant is commonly considered the most difficult implant to place because it's a blind procedure. You can't really see the bone that you're anchoring into back there. Whereas a zygoma, you can see the zygoma that you're anchoring into. The other big difference is there's a lot of really bad anatomy way back here that you can potentially hit with a pterygoid implant. So you got the pterygoid venous plexus, you have the maxillary artery, which you could potentially hit in 2 different spots. You can hit it if you're too lateral, you can hit it if you're too high. And you can also hit the descending palatine artery. And on any one of those arteries, if you hit it during the drilling process, it has the potential to kill a patient very quickly, intraoperatively during the surgery. And so that implant, is actually the more difficult and scarier of the 2 implants. But once you learn all the anatomy, once you learn the proper placement and technique for that, it can make it much safer. The other thing I left out is a quad-zygo. So if anytime we're placing 2 implants into the zygoma, that's always a challenging situation because your zygoma, your cheekbone is only so big, and trying to fit 2 implants in there is always challenging. So a quad-zygo is always tough. So in terms of ranking them, I would say, pterygoid implant, quad-zygo, and then regular zygo.
Okay, how often are transnasal implants used?
So transnasals are a relatively new style of implant. Up until very recently, there had only been a total of 28 published in all of dental literature. The first articles, came out in 2019, and they're, Brazilian articles, in Portuguese, so they weren't very widely read. And in the remote anchorage textbook that I published, we have, I think, 7 cases in the remote anchorage textbook from different doctors from around the world. So, in published literature, there have not been a ton of these done. And the bone that's available for this transnasal implant to anchor into is not always, of adequate dimensions to use. And so in many of these cases where we are analyzing the bone, there's just not enough up here to place one. So the whole point of a transnasal implant is it gives us some anterior support and allows us to preserve the superior portion of the zygoma for a future implant if needed. So it can decrease the amount of quad zygos done, but you have to have adequate bone to engage, up on the lateral area of the nose. And unfortunately for some patients, there's just not enough bone. And then you also have anatomy that we really don't ever have to think about, called the nasolacrimal duct. So the nasolacrimal duct is where the tears from the eye are draining down into the nose. And you also have to make sure that there's enough distance between where this implant needs to anchor into and the nasolacrimal duct, because we don't want to block that. And so the number of patients that this can be used for is definitely significantly less than the number of patients that could get a pterygoid implant, and certainly less than the number of patients that can get a zygomatic implant.
Okay, next question. Can you summarize the maintenance protocol for full arch remote anchorage implants?
So maintenance is something that's often overlooked on these procedures. And the maintenance protocol for these are still very similar to the maintenance protocol for regular all-on-X style treatment. Now, maintenance doesn't get a lot of attention because it's not a very sexy topic, but is very important to the long-term health of these restorations. And there is not a lot of published literature on maintenance of all-on-X style treatment. Now, the American College of Prosthodontists has a position paper on maintenance. And in my textbook, I have an entire chapter, and my position in the textbook is a little bit diametrically opposed to the American College of Prosthodontists position. Now, their position paper has a total of 10 references, whereas my textbook, we have 57 references on the maintenance section. And where we really differ is on whether or not you remove the restoration or you don't move the restoration. So the American College of Prosthodontists in their position paper recommend not to remove the restoration at the yearly maintenance appointments, just to clean the teeth, go over hygiene with the patient. And one of the reasons they recommend not to remove the restoration is essentially based on two articles or two references. One is a mechanical engineering textbook, and the other is an in vitro study. And so not even any clinical studies. And the big reason they recommend not to remove the restoration is because of the screws, that it can cause deformation of the screws. Well, if you look at clinical published literature by many doctors, many respected doctors that have been doing these cases for decades, Dr. Mullo, Dr. Aparicio, they show that in normal functioning of these cases, because you have some cantilever, in many of these cases, you will get some screw loosening. You can even, on the prosthetic screw, you can also get loosening of some of the abutment screws. And in some of the studies, the screw loosening was up to 70+%. And so at these yearly maintenance appointments, in my interpretation of the literature, in 57+ articles for that chapter, the literature to me supports removing the restoration at yearly intervals to retorque all the abutment screws and then replace all of the prosthetic screws. And so the reason the ACP did not want to remove these restorations was because of the deformation of the prosthetic screws. And the way you solve that is replace the prosthetic screws. And prosthetic screws now are relatively inexpensive, and there's really no reason to not replace a prosthetic screw at these yearly maintenance restorations. So when we take them out of the mouth, we'll typically have the patient come back at yearly intervals. We'll remove the restoration, clean the restoration, retorque all of the abutments to make sure they're at manufacturer recommended values, and then replace the prosthetic screws, reseal all the access holes. And then it's also very important to adjust the bite, because the patient's bite can change. You can have changes in the musculature, you can have changes in wear patterns on the restoration. And so at that yearly appointment, checking the occlusion and adjusting the bite every year is also very important. And so the maintenance protocol that we've been using in our clinics for a decade plus, and what the literature seems to support in terms of my research of literature that we put in the textbook, is removing the restorations on a yearly basis.
Oh, that's really interesting. If a zygomatic implant becomes exposed due to gingival recession, is that a problem?
Okay, so this is where the design of the implant becomes very important. And there's many different designs, and there's many different techniques. So you can have a technique that goes through the sinus. And if you're going through the sinus entirely, you don't really have any ability to have the implant exposed because it's all contained within the sinus. If you're using what is more widely accepted today in contemporary treatment is a extra sinus style protocol or a Zaga style protocol, a la Dr. Aparicio's group. And with this style of treatment, you can also often have a portion of the implant outside of the sinus, like lateral to the sinus wall. And anytime you have a portion of the zygomatic implant lateral to the sinus wall, that has the potential for becoming exposed because it's only covered with tissue. And depending on the style of the implant, so if certain implants have a roughened apex of the implant, and that's the part that's engaging the zygomatic bone. And when that is roughened, you're getting better bone implant contact, faster bone implant contact, but then the rest of the implant is a machined or a smooth surface. And when you have a machined or smooth surface, up to the platform, if you have any exposure of that portion of the implant, it's really not a problem because you have a smooth surface. There's less chance for any bacteria, endotoxins from the mouth to adhere to that surface. The patient can clean it better. And in those style of implants, if they become exposed, they're typically not creating a problem as long as there's no oral antral fistula. The patient can still just clean the area. You typically have very minimal inflammation. If you have a zygomatic implant design that has a roughened surface that extends down the implant, say all the way to the platform, that can then be a big problem because if you do an extra sinus protocol with a roughened surface implant, down to the platform, if that implant has any recession of the soft tissue and starts to expose any of the rough surface, now you can have problems because the bacteria has endotoxin, the endotoxin soaks into the rough surface of the implant. The body wants to try to get rid of that toxin, you start having bone breakdown, and now you can have oral antral fistulas. And because this rough surface of the implant is just chronically saturated with bacterial endotoxin, it's extremely difficult to close the oral antral fistula that could develop due to bone loss. And so when you have exposure of those style of implants, sometimes there's no way to treat it, and we end up having to cut the implant and leave the portion up in the zygo, but remove the remainder of the implant that is soaked with the bacterial endotoxin that is preventing the closure of the oral antral fistula. So that's where it's really important to look at the implant design, depending on the technique that you're utilizing for placing the implant.
Okay, next question. Why not just do a sinus lift instead of a zygomatic or pterygoid implant?
Well, you can. I mean, for most patients, sinus lift is still an option. You did see in some of the cases that we presented, sinus lift was not an option because there was no floor of the sinus left, or the sinus membrane is, dramatically thickened. Sometimes patients, maybe they already had sinus lifts that had failed. But, for a lot of patients, sinus lift is still an option. It is going to extend the treatment time because typically you need to let that bone heal for 6 months or longer on average, because you're basically growing bone into thin air, because that's basically what's in the sinus. And then typically, even when you do a great sinus lift, the density of that bone is not going to be anywhere remotely close to the density of the bone in the zygoma. And so, you're typically not going to get near the insertion torque. And so on some of these cases, you might need to do delayed load protocol where you're doing bone grafting in the sinus. You have to let the bone heal. Then you have to come back, place the implants at a later date. If you don't get good insertion torque, you have to let that bone, implant heal. So the patient might be in a denture for, a year plus after you started treatment. We'll have to go through multiple procedures. And then also in my experience on those cases, and believe me, before I did zygomatic implants, I did tons of sinus lifts because, that's the only way I could restore some of these patients. And what I have noticed is on these, especially these full arch cases where you are doing these really big sinus lifts and placing all the implants in a completely regenerated bone and no other native bone. As time goes on, when you get out to 12 years, 13, 14 years, this bone that's regenerated can sometimes start to break down. The implants are still osseointegrated, they're still not moving, but you just don't have as much bone as you did when you originally started, because that bone's just not quite as strong as native bone. It's all just regenerated. And as the patient's chewing, all the finite element analysis studies show, all the stress gets transmitted to that bone. And because that bone is not as strong, many times it just can't hold up quite as well, especially at the crest, and you start to lose a little bit of bone. You can start to now get a little bit of implant exposed. And again, we just went through the whole process of what happens when you have rough surface of implants exposed. So what I've discovered is, implants placed into sinus grafted bone, when you are doing this for a complete arch with no other native bone, can start to have a little bit of issue down the line. I'm talking, 8, 10, 12 years down the line. And if you look at most published studies on sinus lift, especially for full arch, they're not typically giving you 10-year follow-ups or 14-year follow-ups. I mean, most studies are giving you 12-month follow-up, maybe 24-month follow-up. But sinus lift is always an option. And sometimes the zygoma is very thin and you can't use the zygoma. So on some patients, we have to do a sinus lift because the zygoma is just not really a good option for that patient. Now we have some other alternatives, such as the resurgence of the subperiosteals, which not as quite as much research available on that yet with the newer styles, but that might be another option that's available to the patient. But sinus lifts, in most cases, are still always an option for a patient. It's just good to go through all the pros and cons with the patient, and really let them make the best informed decision.
If doing a quad-zygo, do you place the front or back implant first?
So that is, so it's a bit of a matter of debate in the literature. It's literally 50-50. Half the articles on a quad-zygo place the anterior one first, and half the articles place the posterior one first. Now, me personally, I placed the posterior or the inferior zygo first. And the reason that I do that is there was one particular study that looked at computer planning of zygomatic implants versus freehand placement to where they were actually placed. And the implant position that showed the most variability was the inferior position or the posterior position. And so I like to place the inferior or the posterior zygomatic implant first because of that. And that also, once I have that implant in, shows me how much room I have to the orbit. And so I know I can basically bisect that to place that next implant. Now, some people like to place the anterior implant first because that way they can get, the implant next to the orbit first. And, that's always the, scarier of the two implants because you have the orbit nearby. And so they can get that one out of the way first and then, deal with the inferior position. But really, the lit supports it either way. It's really personal preference, whichever you choose.
What is the most common mistake you see with zygomatic implants?
I'd say the most common mistake I see is just inadequate dissection, inadequate flap reflection. And then what ends up happening with that is the docs can't quite see what they're doing. And then the angle of their zygomatic implant is off. And either it's now crossing the zygo and preventing them from placing two if a second one's ever needed, or they're not able to get good stability because they're not anchoring into the heart, the dense bone of the zygoma, because they can't really see what they're doing because the flap wasn't reflected adequately.
Okay. Last question. When evaluating a CAT scan for remote Anchorage implants, what are the most important things to look for?
Well, one, having a large field of view is important because a lot of offices have smaller field of view CAT scans. And the issue with those is they tend to cut off the zygomas. So you need to be able to see the bone in order to evaluate it. And there are ways to get around it. If you have a smaller field of view CAT scan, you can take 2 CAT scans, basically place the patient a little bit off center and capture each zygoma in 2 separate scans. But ideally, we're needing to, look at the density of the bone. We're needing to look at, the volume of the bone and, the relationship of the orbit, zygomatic facial nerves, the position of the infraorbital nerve. And pterygoids, we're needing to look at, how pneumatized the sinus is, the density of the bone in the tuberosity versus the density of the bone in the parietal process, how much bone is available back there, where the descending, where the greater palatine canal is, because that contains the descending palatine artery. And then if we're looking at the transnasals, we're needing to look at, one, is there enough bone there, period, to work with? Because oftentimes there's just not very much bone there. 2, where's the nasal lacrimal duct? Because we certainly don't want to block that with our implant. And so with these, the CAT scan is 100% absolutely needed for these remote Anchorage procedures. And ideally, it needs to be a large enough field of view to show, some of those anatomic structures that I just discussed. Oh, I think you're on mute again. Molly, I think you're on mute.
Oh, I'm sorry. There you go. Okay, thank you so much for your really, I was saying how wonderfully informational your webinar was. Well, thank you everybody for their questions, but we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. After the webinar, also, you will receive an email with instructions on how to access the CE quiz. If you miss any portion of today's webinar, you will receive a recording to view at your convenience. But I wanted to thank you all for attending, and a special thank you to Dr. Dan Holtzclaw and Dr. Justin Moody, and our sponsor for this webinar, Affordable Care. Thank you, and stay safe out there.
All right. Thank you very much.
Thanks, Malik. Thanks, Dan.
Thanks, Justin.